Good morning. Thank you all. I haven't even done anything. That's a very warm welcome, except that nobody's in the splash zone, so you're already afraid of me, but maybe you'll warm up eventually. It's a real pleasure to be here. As Yvette said, I come at it from a very different perspective. I really am a trained journalist. That's my background. I'll tell you a little bit about that in a minute. But I want to talk a little bit to you today about how aid got formed and why, and what we're doing, and really talk to you a little bit about the economic perspectives of what you're talking about. Venu's talk yesterday really resonated because you're going to really see how this is not all about you, it's how you work and have a ripple effect on the whole. The decisions you make on how you practice really have a ripple effect on the economy and on patient care and on all Americans. Finally, so I want to give you some context for that. And as I wrap that part up, I'm going to go into four points and considerations I presented Thursday on Capitol Hill to lawmakers. Now, trust me, I don't think government is the answer, but they are part of the equation. So we have to go and talk to them and let them know, and especially at this really critical time when the Affordable Care Act is going to be repealed or replaced or revised or redlined or who knows what. But we think this is an opportunity to jump in and say, hey, here's some considerations we think you should make. So I'm going to talk to you about the 4 points of view that we're championing, and then I'll take questions. So let me start out with, talk about unique self and how I would never have figured out that I would be standing in front of you today. I went to school to be a journalism major. I went to the University of Kansas. I grew up in Southern California. I went to Kansas so I could study and not be distracted by all the fun things to do in Southern California. And graduated, I wanted to be a magazine editor because I like design. I like writing, I like journalism, and I didn't want my work to line the bird cage at the end of the day. So that was my mission, and I graduated and went back home to California, and I started working at Northridge Hospital because they let me be the editor of their health magazine. And I thought that would be great, and the doctors started coming to me asking me, hey, would you do my newsletter? I need, managed care's taking a bite out of my income, will you help me? I said, oh yeah, I can moonlight, make a few extra bucks, I'll do that. So I started freelancing for the doctors, and pretty soon the hospital administration told me that was a conflict of interest. And I went, I'm helping your doctors on my own time get more patients in your hospital, and you have a problem with that. Well, apparently they did. So I said, I did some simple math, which is all the math I can do. And I said, I can make more money working for the doctors than I can for y'all. So I left. I was 22. And in 3 months, I needed a secretary. And in 6 months, I had a 5-person office. And I was representing most of the hospitals in Southern California as a boutique public relations and marketing firm. So there was Cedars-Sinai, St. John's, St. Vincent, St. Joseph's, all the players, little company Mary, except for Northridge Hospital, who did not want me to work for them, which was fine. So on that goes, life goes on. I never intended to be running a public relations agency specializing in medical marketing. I wanted to be a magazine editor. I wanted to do graphics. But I did what I was doing. One kid comes along, I'm pregnant with the next. I'm like, this is too much. I'm teaching at UCLA, by the way. Every week I'm teaching writing for public relations, helping students like you learn to communicate. And I'm like, I'm getting a little overwhelmed. My next baby's coming and I'm really not doing what I want to do. So sold the firm, financed my motherhood. And the week I get home, the Los Angeles Times calls me up, now that you're clean and sober and you're not affiliated with a marketing firm anymore, we want you to be our health reporter. I'm like, well, wait a minute, I'm having a baby, I have things to do. And they said, no, we'll let you work at home, you do your own time, you understand the Southland and medicine like nobody's business. Will you be our health reporter? I'm like, okay. So I started being the health reporter for the Los Angeles Times, learning an awful lot, talking to doctors all the time about critical procedures, not so much about the financing and the morass that we're in today, but just understanding, the dynamics. I moved to Denver, the LA Times doesn't notice, I'm still writing for the LA Times, and then one day they noticed that, she's halfway across the country and we could really use a senior health reporter at the Orlando Sentinel. So 2011, ready for some life changes. My daughter hates her high school. One of them's already off to college. So she said, I'd like to go to Florida. I'm like, okay, let's go. So I became the senior health reporter at the Orlando Sentinel. This is no design. There's no design here, as you see that. But I think I'm in the right place at the right time. I do. So come to Florida, and I'm like, what's in Florida? It's the 26th largest metro. It's behind San Antonio. It's kind of dinky. And I'm out of LA, like where it's all happening, right? Well, Florida's really strange in that even though it's the 26th largest metro, it has 2 of the largest health systems in the country. 2, not 1. It has the number 3 and number 8 largest nonprofit health system in the country. Florida Health System, Florida Hospital, and Orlando Health. And it is decimating this metro. It is decimating it because of the encroachment it is having, buying up medical practices, buying up clinics, taking taxes off the tax rolls. We'll get to all this. So the fog is slowly clearing as I'm seeing what the heck is going on. As I try to talk about what's happening as these hospitals are merging and acquiring physicians and consolidating, and Obamacare is coming in. I'm trying to cover all that, trying to make sense out of it. There was this one voice that kept ringing true to me. It was an accountant named Tom Thomas. He represented 115 medical groups. He and his partner, Carol Zurcher, have a really fine accounting firm. They have about 24 employees. They're maxed out. They do not take new business. They wouldn't even take me on as a client. So I'm okay, you're busy. So they were seeing firsthand the impacts that hospitals buying up physician groups and turning independent doctors into employees was having on America, on the morale of doctors, on the costs, all of it. And whenever these consolidations would happen, I would talk to the hospitals. They talk about efficiencies of care, streamlining this, electronic medical records that, better for patients. And I talked to the insurance company, and then I talked to the doctors who were between the devil and the deep blue sea because they couldn't shoot their new employer in the foot. So they're like, yeah, it's all good. Then I talked to the accountants, and they go, not so fast. So I was one of the few people in the newsroom that wasn't a liberal. So, I mean, we're a bipartisan organization, but I wasn't leaning the way they were. I listened to the accountant, and he pretty soon figured out that I understood the situation. And he and Carol, his partner, looked around one day in 2013 and said, you know, independent doctors are getting the short end of the stick. They really need to get some representation. Maybe someone should try to start a trade association to give them a voice. Then you know what happened next. Maybe that should be us. So they invited 100 doctors to a room in Orlando, Winter Park, Florida, and each of them ponied up $1,000 to start this little organization, the Association of Independent Doctors. That was April 2013, I'm sorry, and I wrote the story for the Orlando Sentinel. It was on the front page. Independent doctors unite to fight national trend toward hospitals buying physician groups. That story got shared, and pretty soon, the 100 became 200, and they went into 4 or 5 states, and they were starting to grow. Fast forward, summer of 2014, Tommy and Carol called me to dinner, asked me to dinner. I thought they wanted more media, which is why I usually get asked to dinner, and they said, no, we want you to run this association. It's gotten too big for us. We have a full-time accounting firm. You understand it. We know you have 2 kids in college, and the future of medicine isn't looking, or future of journalism isn't looking too great. They're right about that. They are accountants after all. And said, we really would love you to be a communicator and get this message out, because we can't, we're busy, and also we're boring. And I told them I agreed with both things. So I accepted the job. And in September of 2014, I became the executive director of the Association of Independent Doctors. And since then, and really since Tommy and Carol, this is supposed to, just kind of watch these headlines. You can see them. Can you see those? Since Tommy and Carol started this association, not just because of them, but because of efforts like the Benjamin Rush Institute and other institutions that are supporting independent doctors, the headlines are just the story is coming out that this business of acquiring doctors and turning them to employees is having a very negative effect. So some of these headlines were thanks to us, some of them were thanks to others, but the point is we're starting to bubble up. The AMA was not speaking out on behalf of independent doctors, and we felt somebody had to. So as the news got out, aid started to grow. I've spoken on Capitol Hill now 5 times, and I've spoken to a lot of medical groups, and we are now in 31 states, and we have 1,000 members. So in the 2 years I've been there, we've tripled in size. And we have, as soon as this is done, I'll show you where our map is, and we'll talk about what we're doing. That's the last one. So you get the message, right? So we've got chapters, critical mass in Florida, New England, California, and Southern California, and South Carolina. That's where we have about 20 or 30 doctors where I can have actually more impact, because I can call up the lawmakers there and say, I have 30 physicians in your state. They each have 2,000 patients. They're all voters. Listen to me. If I have 1 or 2, it gets a little bit harder to do that. So we're starting to get some critical mass in important places where we can get the word out. It's where we're based. I'm kind of happy to see that get filled in. It isn't as exciting as November 8th map, but it's pretty good. Okay, so here's the problem. Since 2000, in 2000, America had 57% of its doctors were independent. Today, that number is 1 in 3. Going the wrong direction. We think that's a bad idea. Now, I totally get where you're coming from, why doctors do this. They, especially when they're coming out of medical school and they don't even have a practice to sell, they don't even have a practice to give up, and they have all this debt, right? So they see money, They think they're going to get more money. We'll talk about why hospitals can afford to pay them more money, and that's something we're trying to level out so there's less incentive for hospitals to be acquiring doctors. They think it's more secure. We'll talk about that. Somebody else covers their overhead. They really didn't go to school to learn about how to manage and how to market and how to do billing and all that, so the hospitals can take care of that. That's very attractive. Get that. In this environment with Obamacare, the shared risk becomes important. They're like, shoot, what if I have some outliers that really skew up my track record and my numbers, and I'm not going to get favorably reimbursed. I'll get penalized for my outcomes. That's not good. The hospital automatically generates referrals. If you call a hospital and ask them for an OBGYN, they will only refer you to an employed OBGYN. They won't refer you to the independent ones. So they have this channeling mechanism. So it's unfair, of course, but that's the way that works. Even if the independent doctor's on staff at the hospital and has the best record, they will only refer to the employed physician. And the thought of investing in electronic medical records is daunting. And if the hospital can take care of that for them, they're like, I'm in, right? We all get why they do it. And why did hospitals do it? They capture the control in the market. They can channel their referrals right into the mothership. And they boost their diagnostic tests because you're going to see in a minute how they incent the doctors to order more tests and overutilize because they want to make money and the doctors want to stay employed. And they get more money for the same procedure because there's something called facility fees. We'll talk about that too. Lots to go over here. So basically, this whole idea of consolidation, the hospitals are incented to do this. They're on a buying spree because the bigger they are, the more money they can get, the more market they can capture, and the more bargaining power they have with insurers. And guess what that's doing to costs? Up, straight up. And that's what's been going on. So this whole idea of consolidation and merger, and it's all tied together with some key points here that we're going to talk about. Less competition. There is no study ever that has shown that consolidation reduces costs. Yet, every hospital that goes out on a buying spree and buys up another hospital or a medical clinic or a group of doctors will talk about streamlining efficiencies, lowering costs, providing better care. Doesn't happen. In fact, the opposite is true. The studies all show that costs go up and quality goes down. The quality goes down because the independent doctors can refer to the very best doctor they think for the job. Let's say you have a breast lump. It needs to get removed, needs to get analyzed. They're going to refer you to the very best breast surgeon who probably is not an employed physician, or they wouldn't still be independent. But the employed doctor has to refer to another employed physician, and a breast surgeon who's employed by the hospital, because anything that goes outside of the mothership is called leakage, and it's strongly reprimanded in terms of the next contract gets worse. So your quality of care, the poor unwitting patient has not a clue. Doesn't go into the doctor and say, excuse me, are you independent or are you employed? That's not his first question or her first question. It's, do you take Blue Cross, right? So they go into this system and don't even know they're getting worse quality and higher costs. They have less choice of what I just told you. The bandwidth of who these doctors refer to gets narrower if they're in the employed system. They don't get to go out of the system. And we're going to see how that impacts costs, which is dramatic. How many of you know what facility fees are? All right. Yeah. These are really important and invisible. These are fees that hospitals layer in onto a doctor's procedure that an independent doctor either doesn't and can't layer in. So the facility fee is something the hospital argues, and the American Hospital Association has been very effective at saying, gee, we need to keep the lights on 24/7. We take care of the sick and poor at all hours. We need to keep these monolithic buildings up. So we need more money than the independent doctor. So pay us more for the same procedure. Now, how does that factor into, this is very important. So I don't know if you can see that, but this is from the Medicare Payment Advisory Commission. This is a group that the government has set up for Medicare to look at Medicare and say, gee, how could we save costs? And every year the Medicare Payment Advisory Commission says, get rid of the facility fee. Every year they are ignored. Now, that's because we have some strong hospital lobbies. So, but these are I didn't cherry pick, I just picked three very common procedures. An MRI from $319 to $1,591 with the facility fee layered in. Heart cath quadruples from $1,100 to $4,000, almost quadruples. EKG goes up 4+ times. So, okay, so that's per procedure with the facility fee layered in that we don't get to see because there's no transparency. Talk about that in a minute. So how does that manifest itself in our healthcare system? Okay, so I hurt my knee. I go to my primary care doctor. He says, gee, you really should see this orthopedist. My independent doctor refers me to an independent specialist who refers me to a freestanding MRI, which we just saw was a fourth of the cost of a hospital-owned MRI facility, who sends me to a freestanding surgical center so I can have an arthroscopy and get it repaired. Okay, maybe it costs $5,000, $10,000, $10,000. On the other side, everything is going to conservatively triple. Conservatively triple. Often it's 10 times more when you layer in the facility fee. So if more doctors are employed and more doctors are referring to other employed doctors, look what's happening to our healthcare system. Look what's happening to our healthcare costs. That is one of the biggest reasons the costs have skyrocketed. It's not the doctors. The doctors are 8 cents of the dollar. It's the hospitals. So just one example, here's again a client report from Milliman to the American Medical Association. Just in advanced imaging, the difference between hospital outpatient and inpatient was 36 to 53% higher. We're talking real money, folks. USC did a study that for just chemotherapy, if you went to a doctor who was employed versus one who was independent, it was 34% higher your costs were for chemotherapy. Same care, well, same medication, probably better care if you're at an independent facility. This was another study in JAMA. If independent doctor, the mean cost for your inpatient procedure is $3,000, where it's $4,700 if you go to a multi-hospital system. Why is that? Because the employed doctors, their next contract is based on how many patients they see, how many procedures they order, how many heads they put in beds. And if they don't meet their numbers, their contract gets worse. So they are incented to order more procedures. And the cost of more people die of medical errors and hospital mistakes in this country than live in the entire city of Miami. 440,000 people die every year because of mistakes in the hospital. Best way to avoid that is to stay out of the hospital and not have more procedures that you don't need, right? So it's putting us in harm's way and raising prices. And fundamentally, and this is really important for you, when you're an employed physician versus being an independent doctor, now you're all in medical school. You did not go to medical school to figure out how you could extract the most money possible from every patient. Can we agree on that? You went to do what's best for the patient, but you've got this hospital in your ear saying it's all about your numbers. So your allegiance shifts from the patient, the doctor and the patient, to your employer, because that's who's buttering your bread now. It just happens. It's inadvertent, but it does happen. The allegiance shifts. I need to please them. I need to order more tests. And maybe it's not in the best interest of my patient, but it'll make my boss happy. Not the way to practice medicine. So MedPAC, again, said, oh, by the way, guys, if you got rid of the facility fees in 66 of the most common groups that we order tests for, we order procedures for, 66 groups of services, taxpayers would save $900 million a year. Let's call it $1 billion. That's real money, folks, and that's just Medicare, and that's just the 66 procedures. So what if it was Medicaid, and what if it was all commercial health insurance? That would be a lot of monies. So this is what I spoke in DC about 2 days ago, how to save $100 billion of healthcare. And we can all agree, digressing for just a minute, we all talk about access. Access, people need access to healthcare, and for access they need coverage. Folks, insurance coverage does not equal access. Access is not an issue in the face of affordable care. If we can get the cost down, access isn't a problem. People can afford it. So we're trying to, if we can save hundreds of billions of dollars, guess what? The access ceases to be a problem. So one state, God bless them, Connecticut, the governor went to get a test, and it was an MRI of his back. He's like, this should be like $1,000. It's $15,000. What's going on here? Well, he found out about facility fees. He thought that was a really bad idea. So he got into law in the state of Connecticut. It is a law that hospitals are required to disclose their facility fees. Yay! So the patient goes and says, it doesn't say he eliminate them, which would be even a bigger hallelujah, but what it is saying at least the patient can see, oh my gosh, here's the doctor's fee, that seems reasonable, then there's the facility fee, which is 3 times what the medical professional fee is, and that's really raising costs. And furthermore, the Connecticut facilities have to say, not only do we charge this facility fee, and here's how much, in advance of your appointment, not after you get the bill, they have to disclose that, oh, by the way, if you go to an independent doctor or a freestanding independent facility, you will not have a facility fee. Okay, I'm just talking, let's just do transparency, folks. Let the consumer think about it. Let the consumer go, well, I can pay $300 here or $1,500 here. What do I do for the same thing? Well, so transparency would be huge, and transparency of facility fees would be even bigger. We tried to get this law passed in Florida. I wrote the resolution, presented it to the FMA, took me 2 tries. This is a bipartisan concept. People on both sides of the aisle want transparency. The hospital doctors are, this FMA has employed an independent doctor, so you can imagine there's some resistance. The employed doctors don't want all this out, but they realized it was in the best interest of the patient. So we actually got the bill up to the legislature in Florida. But guess who's the president of the Senate? A fellow named Andy Gardner, who is a vice president of strategic planning for Orlando Health. He has a full-time job at the hospital preventing just this thing from happening. It never got to the floor. So, okay, folks, I don't have so many years to live, and I can't have this argument 50 times in 50 states, so I'm going through the Capitol about this, hoping that the Trump administration sees the light and can make a difference. Trying. Thank you. So we are making little baby steps. I told you I had a chapter in Maine. Well, because I have a chapter in Maine, with 250 doctors in Maine are members, I think that's almost the entire population, and that gave me access to the governor, who's the heavyset fellow next to me. 2 of my AID members who are from Maine, they attended a meeting I had with Governor Paul LePage. And he's a very bright man. He's not endeared, not everyone adores him, but I think he's a straight shooter. And we told him about facility fees. We told him what was going on, and this was insane. It was raising his healthcare costs. Well, governors can only do so much. They can only control state dollars. So I get an email the other day from his legislative aide. She puts, this is his budget for 2017-2018. He put a line in there, thanks to us, she said, that they are eliminating the facility fees for hospital-based physicians. Okay, it's the state of Maine. We have 2.3 million people. It's a dinky state. Just in Medicaid, if they remove the facility fee just in Medicaid, not Medicare, not commercial insurance, the state would save $11.4 million. Real money, folks. Now, let's take that across all 50 states if they roll back the facility fee. And guess what? The rest of the money that's not the facility fee goes right to the doctor who's providing the care for the patient. It goes really where it should, between the patient and the doctor, not to the facility fees, not to these hospitals that have baristas and valet parking and marble fountains. I'm sorry. The money needs to go to the patient and the doctor. So, hooray. Now again, I can only do this so many years, and I'd like to see this happen in every state, but it's a start. All right, higher costs. Where was I going? 7 consequences. Fewer jobs. Okay, so I have a medical practice, and I've been running it for 15, 20 years. We've been doing a nice job, and I have a very loyal front office person. I have a very loyal back office person. They've been with me all this time. The hospital, but it's getting harder and harder to make ends meet because the insurance companies keep cutting my payments while they pay the hospital more, because the hospital now is getting bigger and can extract higher reimbursements from the insurance providers. And in order to make ends meet, the insurance providers cut the fees to independent doctors, which is causing this whole flywheel of purchasing the doctors to begin with. So anyway, so there's a doctor struggling to make ends meet. Now we have EHR, now we have Obamacare, now we have all these legislators coming in, and he's just going like, I can't do it anymore. Excuse me, she can't do it anymore. And the doctor says, fine, you can buy me, just buy me, and I'll go to work for you. I'm caving in, throwing in the towel. His front office staff loses their jobs because the hospital's taking care of all that for them now, doing all the billing, all the admission, all the scheduling. Now they may say, oh, your staff can stay in place until the next contract. But then it goes south. So these are people who have real jobs, who are loyal, who are doing a good job, going out in the community, buying, going to the dry cleaners, going to the movies, going to dinner, living a life, and that now they're gone. It's over because of the consolidation. That's wrong. And this one is probably the biggest abuse of the tax code going on right under our noses in America. Yes?
Sorry, I didn't mean to interrupt, but
yeah.
I had a sister that's a nurse, and I wonder if you deal with the nursing, because I've seen exactly this happen where the RNs kind of crush it out, where they buy the primary care, and if they had an RN that was working for them, they only want the LPNs in the hospital because they can pay them less.
Right. Well, the dilution of the statures in medical profession is going on. It's rampant, and I've written essays, and they've been published about don't call me a provider. Don't dilute MD down to NP, down to LVN. They're not all providers. They are, quote, providers, but they're all very different. So I think the distinction and the qualifications need to be featured, not buried. it's a slightly side issue. Okay, in America, 62% of our hospitals are nonprofit. Let me rephrase that. 62% of our hospitals are tax exempt. They make plenty of profit. That's 3,900 of our 5,500 hospitals. These hospitals pay no tangible tax, no property tax, no sales tax, no state or federal income tax. Okay, yet they have, and I'm just looking in Florida because that's my little bailiwick, those two monoliths I told you about, Florida Hospital, Orlando Health, have 8 executives who make 7 figures or more, millions dollar salaries plus. Some make $4 million. Okay, they do not sign a chart. They make more than almost every single physician in their employee or in their hospital system, their staff. And as they acquire these little businesses, these little medical practices, or some of them are large, 35 doctors, 17 doctors in a swipe, all the money that those little businesses used to pay into the community come off the tax rolls. Okay, so I was making this clear to one of my former colleagues at the Orlando Sentinel. I said, you know, you really should look into this. If I were still at the Sentinel, I'd be diving right into this story. And I helped her tee it up, and I helped her look at just property taxes in these 2 hospitals, right? And we're the 26th largest metro. We're just a middle-sized metro. These 2 hospitals in just property taxes would have paid into the community $50 million. That's sink in. They do not pay, let's put it another way, if they were a real business paying real taxes, they would have paid $50 million in taxes. That's a lot of roads, police officers, teachers, and free health care. $50 million can go a long way. But instead they're buying skyboxes, they're buying islands, they're buying Lear jets. They're having a grand old time. They're nonprofit. Folks, the nuns are gone. There was a day when nonprofits really meant nonprofit, and these nuns didn't take anything for themselves, but gave it all back. It really worked that way. It's a total boondoggle, and we're all getting sucked into it. It's driving our costs way up. This is why, get your little microscopic eyes out there. This is why, if you can see, y'all probably have heard of charge master pricing. Stephen Brill did a great job a couple years ago in Time magazine, and he wrote The Bitter Pill. And he exposed a lot of this, that hospitals have retail rates, what they say the cost of their care is, and then actual. Now, Medicare, for all its faults, does a pretty good job of analyzing what procedures really should cost. People can really look at Medicare and say, if this is what Medicare would allow on a particular procedure, that's pretty much what it should cost. And if the hospitals can't make that work, it's the hospital's problem. So Medicare allowable, you'll see, is on the right-hand side, just in the top one, transient ischemia. $30,000 is what the hospitals say it costs. Medicare allowable is $4,700. Keep going, $52,000 versus 9. We're talking about a 5-time delta here, and it goes on. The reason this charge master price is significant is because on the 990s, a form you never want to have to look at, but I've been into many of them. These are the charitable contribution forms, what nonprofit hospitals have to submit to the government to justify why they don't pay taxes. If you look at it, this is what they're using to say what they're giving in free care to the community. It's a joke. They're using charge master prices that nobody would pay. So it's these hugely inflated prices. Oh, and by the way, for-profit hospitals give plenty of free care with no tax exemption. Folks, if the hospital is not behaving like a nonprofit, if it is paying its executives million-dollar salaries, and I think that nobody who works for a nonprofit should make more than 10 times the average wage of a person in that state. So let's say the average full-time worker in Florida is $45,000. I'm making this up. No nonprofit executive should make more than $450,000. Just a rule of thumb. It just seems to me that would be reasonable. All right. So where's this money going? All this money that's going to the hospitals in facility fees and tax exemptions, tax savings. Well, the little teeny brown line at the bottom, that's the growth of physicians between 1970 and 2009. The yellow line, that's the growth of hospital executives in the same period. That's a lot of money for people who don't do anything but get in your way and tell you how to practice medicine. I've had a lot of doctors tell me, I really get tired when a person with a 4-year degree tells me where to do rounds first. me with 12 years of education, and I have some hospital administrator with a bachelor's degree telling me what gloves I can use, what knee replacement I can use, and where I should make rounds first because it's more efficient. Yeah.
Really quick, do you know what's happened since 2009?
Yes, I have it right here. So stand by. I'm glad you pointed that out because this was 2009 before Obamacare, folks. So listen here. This is also the Bureau of Labor Statistics. They're the ones who presented this. This is from them too. The Bureau of Labor Statistics notes that employment among medical and health service managers, what a vapid term that is, has increased by 31.5% since 2011. So we have a 2-year gap here. But from 2011 till now, these are administrative workers who don't treat patients, but merely ensure compliance with federal and state mandates. And they help explain why U.S. healthcare is so expensive. This is going to be painful, but this needs to get corrected. All right. Okay, higher taxes. Now, finally, I promise you 7 points, right? It sucks to work for the hospital. Bottom line, you don't want to go there. The happiest doctors I know, and they tell me, the ones who are on the inside and the ones who are on the outside, the happiest ones are independent, by far. Some of them are miserably independent, but they're happier than miserably employed. I'm sorry. Doctors are getting burned out. I mean, they're between the devil and the deep blue sea. If I stay independent, my reimbursement rates go down. It's hard. I have more and more regulation. It's just I get beat up by the hospital. The employed doctors get all the preferential treatment. They get the best OR times. They get their labs done back faster. I'm bullied. Yeah, it happens. But it's way better than having the hospital minister, that big yellow bar of people running your show. Okay, so what are we all doing here? This is frustrating. I mean, if I weren't for you guys and there was a little hope in the world, I don't know if I could get up every day. But we are trying to push for parity and transparency. What we want to see happen, transparency in prices, so consumers can start shopping and not, where else do you go in to get something so expensive and not have a clue what it costs until you get the bill when you're, recovering from open heart surgery, then you have a stroke, right? Because you don't know anything going in. Nobody knows. So we want the consumer to be able to shop pricing, because if the consumer can shop price, they're going to start making more intelligent choices and choose the more affordable independent care as opposed to the employed machine, the corporatization machine, which has completely apathetic to your care, is looking at you like an ATM machine, and is not interested in really benefiting anybody but themselves. Parity, as I told you, that mechanism where the hospitals can extract more and more payments, greater reimbursements from insurance for the same procedure because they have so many patients now, because they've accumulated so many practices. The insurance companies have to find out where to get the money from, so they cut the reimbursement to the independent doctor, and that delta gets wider. So we want to have the same pay for the same procedure, regardless of if you're employed or independent. That would slow down the hospital's appetite for buying up practices. We want to talk to, now this is what we do probably as well or better than most other associations that do what we do is because of my media background. We go out to the consumer and we talk to them about the importance to go to independent doctors. I go to them and say, the number one question you need to ask your doctor is what? Are you employed or independent? That is going to set up the trajectory of your care like no other question. Then you can ask, do you take Blue Cross? We have on our website a directory. If you want to find an allergist in Oklahoma that's independent or employed, they can go there and find that independent doctor. So I try to get that message out to the media and tell them this is something your patients need to know. Because media cares about pocketbook issues. When I was in the media all these years, they want anything that affects the consumer's pocket, gas prices, healthcare prices, really important.
So it's not just employed or unemployed, it's like hospital employed. Because Josh Umber employs physicians, and these guys are going to come out of medical school with debt, and they may want to be, so it's not every employed physician is the same. So.
Yeah, hospital employed physician, yes, that's an important distinction, and that is what I mean. Thank you. And when we're trying to challenge a tax-exempt status, we think it's ripping us off. It is ripping us off. So we work with the media, work with businesses, work with lawmakers, and work with doctors. Okay, so now I've gotten you thoroughly depressed. So what are we doing about it? So Thursday, I was in Washington, D.C., speaking on Capitol Hill in the Library of Congress. These other folks are all physicians. They were with me speaking out. So here's the difference. I come with that education from accountants who are very bright financial people, and I'm a journalist. We're very different from the physicians who come and lobby on Congress for a couple of reasons. First of all, I tell my 1,000 members, when you all go and complain, it sounds like you're whining. When I complain, it sounds like I'm advocating. So y'all go remove that gallbladder. I can't do a lot of stuff. I can't remove gallbladders or read an x-ray or deliver a baby or replace a knee, but I can communicate complicated things in a simple way, in a way that makes people matter, in a way that looks like I don't have any agenda. I'm not gonna lose my parking space at the hospital. It doesn't matter. I just care about what's happening for the American people. So I think coming at it as a journalist actually has some real advantages. Okay, so I talked on Capitol Hill, and I have these packets now. You guys can put these on the tables if you want. I have a few of these packets left that I did not distribute on Capitol Hill, and you're welcome to them, like 5 or 6. But it has this information in it and a little more detail. But I said if you could do these 4 moves, we would save hundreds of billions of dollars in America. We would dramatically improve quality and access, all while helping America's doctors. My whole story is what's good for the American independent doctors is good for Americans. Now watch how this works. So one is stop the consolidation. We all saw what happens, right? When these hospitals keep getting bigger and bigger and bigger. And by the way, AID has been involved with the Federal Trade Commission enforcing antitrust laws and written amicus briefs. I personally wrote 2 amicus briefs. I'm not a lawyer, but when I told the FTC I'm not a lawyer, he said, I'm a journalist, he said, well, that would be refreshing. So why don't you write it? It was a legal paper, okay. Fighting 3 major consolidations. One before I got there was in Idaho. Somebody from Idaho, that doctor that spoke the other day, when St. Luke's Health System was buying a 45-doctor medical group, FTC said that was a violation of antitrust law. It went all the way up to the 9th Circuit Court of Appeals, because the hospital didn't, Idaho District Court said, yeah, it is a violation, you need to unwind that thing. And they said, no, we don't want to do that. We just bought these 45 doctors and we like what they're doing for us. Went up to the 9th Circuit Court of Appeals. AID, before I got there, hired a Washington, D.C. based attorney to write the amicus brief to say, don't do this. Uphold the lower court's decision and unwind this merger, and we won. Then, no good deed goes unpunished. I'm starting to work. I write an editorial. I see this merger happening in Pennsylvania. Hershey Medical Center and Pinnacle Health System trying to merge in central Pennsylvania. And I'm like, this is bad. This is bad for the community. So I wrote an editorial, which was in one of the papers up, actually it's about 6 of the papers up there. FTC sees it, calls me up and says, and I said in my editorial, I sure hope the 3rd Circuit Court of Appeals has the same clear-eyed view of their antitrust law that their colleagues in the 9th Circuit Court of Appeals has and stops this thing. This is bad. This is bad for the community. It's bad for healthcare. It's bad for doctors. It's bad for patients. We won that one too. So I wrote the amicus brief for that. We won that one. And then the same month, this is how I spent my summer vacation. They wanted me to do it again in Advocate North Shore case in Northern Illinois. And that case is winding down. We are going to win that one. We wrote an amicus brief saying, do not let these 2 systems merge. This will be a disaster. And the hospitals are very powerful and have strong arguments about why this all needs to happen. Great with the smoke and mirrors, efficiencies, quality of care, blah, blah, blah. So anyway, so we're doing stuff. So we want to stop the consolidation. So our ask to the administration, and again, I truly in my heart don't think the government is going to solve this problem. In my heart, I think it's going to be consumers and business that solve this problem as they get more educated, as we help them understand and take this smoke away from the veil of confusion that has been sold to them through, I'm sorry, but liberal press, and I'm part of it, and just bad information. But we would ask the Trump administration to remove the incentives driving the trend that are causing hospitals to want to buy doctors and other medical facilities. And the incentives are the parity, right? The increased money they can get reimbursed. We think that should be neutral. And the tax advantages. We'd like to increase price transparency. We don't think that consumers should ever have to buy anything where they don't know the price going in. And we think they should have that available to them up front. And everyone says, oh, well, the prices are different for everybody. Fine. Tell me what the cash price is. Tell me what it costs you, what you need to sell this service for to make a profit. And then I'll see if my insurance is in line. And when that starts to get revealed, and you ask insurance companies, oh, would you please post your prices where all you have contracts at all your facilities so the patient can go, gee, if I have my baby here, it'll cost me $4,000. But if I have my baby here, it'll cost me $2,000. I think I'll go here. It's still covered. That kind of transparency would start helping to correct the market. this is a catalyst for patient reform. We don't know the price of our health care because many states have laws that allow hospitals and other providers to keep costs hidden until they send you the bill. What kind of law is that? Okay, so we would ask the administration, and this is what my packet here says, and what I mentioned on Capitol Hill, to encourage transparency, ask the medical groups and clinics to post their prices, their cash prices, so consumers can start to make informed decisions. Pretty fair. We would like to eliminate facility fees and promote parity, equal pay for the same independent doctors versus hospital employed to get the same, so the hospitals aren't able to lure them with big salaries, which is attractive. By eliminating facility fees, we could move towards site-neutral payments, require payers to pay doctors the same amount for the same procedure regardless of where it's done. Does that sound fair? Do you see how this is good for independent doctors? If facility fees were revealed, independent doctors could flourish because people would start to choose them. If consolidation were discouraged, independent doctors could flourish because hospitals would stop trying to acquire them. And they get vicious about the way they acquire doctors. You will not believe the games and lengths they go to bully doctors into coming into the fold. So that if we could take away the incentives from consolidation, independent doctors could flourish. If we increased price transparency, independent doctors would flourish. If we eliminate facility fees and promote parity, independent doctors would flourish, and so would Americans. So we respectfully ask the Trump administration to abolish the facility fees, require site-neutral payments, do what the Medicare Payment Advisory Commission has been asking them to do all this time. Why do you have a commission if you don't follow their advice? It's ridiculous. Eliminate the incentives for hospitals to create monopolies. We would save billions, hundreds of billions of dollars in healthcare. Stop the abuse of the tax-exempt status. I hope you're all pretty riled up by now, because I am. All right. We want to end the abuse of tax-exempt status by requiring nonprofit hospitals to provide true, not inflated, charitable care, which they can truly account for, or pay taxes. Just pay taxes. A lot of for-profit hospitals provide that same charitable care. I mean, their idea of charitable care at Florida Hospital is to send out what I call the mammobile, the portable mammogram machine to places of employment where people have insurance and troll for women who do not need breast biopsies and scare the hell out of them so they can come in and get their biopsies done in the hospital. That's their idea of charitable care. I think that's off. And, start to eliminate the problem of excess hospital executive compensation. It's excessive. These moves would return billions of dollars to our community. All right, so if we made these 4 moves, we cut the glut, hundreds of billions of dollars, improve access, restore the doctor-patient relationship, right? And my bottom line is, what's good for America's doctors is good for Americans. That's my story. Oh, let me just say it. We're like Beth said, one of several. We have our association. We are not some pointy-elbowed association trying to budge everybody out of this area, of this space. We are linking arms with groups like Let My Doctor Practice and Benjamin Rush Institute and Physician Women's Together and the Association of American Physicians and Surgeons. There are others, but we are working on this together. And we all come at it with a little different point of view. Benjamin Rush Institute obviously is working with students to help guide them and enlighten them about what's going on and to frame their models of care in a way that is not made apparent to them when they're in medical school. We're all doing this together, and we're all collaborating on this together. So we're not trying to knock anybody out of here, but we all come at it a little differently. And I think our financial and journalistic perspective gives it a little bit more of, and less self-serving perspective, to be frank, because we're not doctors. And we have full-time people doing this that are not doctors, maybe have a point of view. But we all have this in common, all of us, speaking out against government intrusion, against hospital takeovers, and against insurance tyranny. This is where the Venn diagram comes together. Okay. Any questions? Thank you. Thank you. Yes?
Could you elaborate more on where the money really goes in some of those organizations? Because, if you look at the statistics, like Becker's Hospital Review put out that nonprofit hospitals cost on average like $500 more per day in the United States than for-profit hospitals. And you made the point that some of the executives are really highly paid, but even if you have 8 executives making over $1 million a year, that's $8 million. That's not accounting for quite that volume of care. So where does the money go that they're charging so much more for?
Well, that chart that showed all the different management layers of healthcare workers, they're not providing medical care, so there's that. The two hospitals where I work both put up $30 million buildings, patient towers. We don't need more beds. We need more competition. We don't need these hospitals to get bigger. And they find ways to spend the money, let me tell you. They're not running efficiently, and they're putting, Florida Hospital has $4 billion in unsecured assets. $4 billion. They could, let me put that in context, they could provide care for 6 months at all of their hospitals, not charge anyone a dime, and still not be out of money. That is not how a hospital, nonprofit hospital should behave. They are putting it offshore, they are banking it. Yes?
A few of us have watched a documentary called Cold Black, and they really try to highlight this vicious cycle that's related to damage on ER physicians because of terrible access to care, improved reimbursements, seeing patients that don't have funds to pay. If these hospitals are making so much and not paying taxes, why is it that we still have this issue happening in our emergency department?
The American Hospital Association spends $20 million a year lobbying on Washington. Independent doctors spend, anybody? Who said what? Zero. Zero. Nothing. It's important. They get what they want. Then they line pockets and throw money at a problem. They don't, the lawmakers just say, oh, okay, well, we'll protect you. And they're insulated from a lot of this. And it's going to take the consumers getting awareness. And, you know, and the problem with a lot of consumers, well, one, they don't feel sorry for doctors. They don't think you guys have it so bad. Sorry, that's just the way that is. Okay, we'll try to get over that. The other thing is they don't want to think about their health care until they need it. And when they do, they sure as hell aren't going to be in the bed arguing with their doctor and their hospital administrator about what's going on, because it's like arguing with your waiter who's going to go spit in your food. You're going into surgery and you're yelling at them for the cost of their facility. Not a good time. So you even Stephen Brill, I don't know what they did with him, but he wrote that article about the bitter pill, and he really nailed it. And then he had his own heart event, and then he became very sympathetic to hospitals. Now, I get the people who provide the care did the job, got it done, but the infrastructure is the problem. So, and they're very well insulated. They've got bright people fighting for their turf, and they've done a very good job while the medical profession was busy saving lives and kind of asleep at the wheel on what was happening to their profession. So we're trying to right the ship, but it is not an easy one to turn around. Yes?
I'm so glad you keep bringing up Stephen Brill. Have you read his book?
The Bitter Pill. I did not read the book. I did read his 57,000 word article in Time, which is almost the book.
Okay. Yeah. So in his book, he kind of expounds on that, and then more about the ACA and his thoughts on it, and explains the sympathy for the hospitals, which is not quite sympathy.
Not buying it, yeah.
In the end, he proposes this that I wonder if it's fitting that you brought up UPMC in one of your pictures.
Mm-hmm.
Because
they're one of the worst offenders.
Because he claims that it's because their hospitals are run by business, and he contrasts it to two that are in New York that are run by physicians, and like the different cultures that they have.
Now, I agree there are some hospitals that are worse than others, but there aren't too many nonprofits that are angelic. There may be a couple, but it's like anything else, it's a continuum. You know, it's the really, really, really bad and just the really, really bad. So I think there's shades of difference. But and I know in some academic hospitals, it's a quagmire. I don't think they're all intentionally evil, but I didn't say that right, did I? They're just trying. I mean, I have interns come in from UCF every quarter. We get a new intern, and they're getting their master's or their bachelor's in health services administration. And they have totally drunk the Kool-Aid. And first thing I say is, look, if you work for me, I'm not guaranteeing you're going to get a job in healthcare. Just starting, just saying, let's be transparent up front, because they don't like me. The hospitals don't like me. They don't like what we're doing. We have that counterpoint in the news all the time. It's all right. So, but these healthcare administration graduates are learning how to do this. You know, I don't know. It's a lot. I don't know. But it's going to start. The truth will shine through. It will. I believe in it. It's just might take a little while. Yes.
My question for you is, so where I'm from, all these independent emergency rooms box to box, it's like every single corner and gas station where I'm from has all of these. And so for my community, it's been like, this is great. You know, You don't have to go to the hospital. They're fully equipped emergency rooms. You're just going to get the same care, but you don't have to wait in line on these things. So my community, we're all like, wow, this is awesome. So then you go to this clinic, you get your care, and then we're still getting charged an outrageous amount, and then they're still running like every test. And so for me, my question for you is like, this is something that's not hospital associated, and so instead of, you know, giving my community a nice positive view on these independent practices, it's putting a negative sour taste in our mouth. So how can we like fight that, and like why do you think that's going on, even though these people aren't affiliated with the hospital?
Well, few things. I mean, I would be triple sure to make sure they're not owned. In Florida, we have CentraCares, which looks just like that, and they are all owned by Florida Hospital. They have 22 facilities. It looks like a freestanding urgent care center, but they're feeders into the hospital. So make sure they're really not part of that machinery. There's another group that it's the same, everything applies to folks with venture capitalists are coming in and creating like advanced dermatology. There's a veterinary one. There's an anesthesia one, American Anesthesiology or something. They're venture capitalists, and they're doing kind of what the hospital administrators did. The hospitals are interested in buying the kinds of practices that put patients in the hospital, and that makes sense. The oncologists, the cardiovascular surgeons, the orthopedists, right? This group, praise is the word that came to mind, praise, but it probably is too strong, goes after doctors who don't necessarily admit to the hospital, dermatologists, plastic surgeons, ENTs, ophthalmologists who do a lot of outpatient stuff, and anesthesiologists and they band them together and do the same model. They get a lot of patients and they can extract higher payments from the hospitals because they're representing so many doctors. The doctors cave into it for the same reasons. They're stressed, their reimbursements are going down, it's harder and harder to practice medicine, and these venture capitalists come in and say, we'll take care of you. We'll pay your salary and you don't have to worry your pretty little head anymore. We'll take care of all that. So it's the same dynamic. So you have to look at who owns it. We have a couple in our community that are coming up that we really do support. They're actually members of AID. It's GuideWell. And believe it or not, they're owned by Blue Cross Blue Shield. And Blue Cross, and some of the executives on high, and I talk to some of them a lot about what they're doing here, but they know that it's costing them more and more money to send patients to the hospital versus into these outpatient centers. And they do have their prices posted. When you walk in, you know exactly what their cash price is. They are transparent. There aren't very many of these around, but they're starting to be the difference. But the first step is for the consumer to go into it and ask, what is this going to cost, and where am I going to get my bills from? And try to get as much transparency as you can. And you may not right now. You may still not get it. But yeah.
One question, just following up with her. This other model that you were talking about, are they also considered a nonprofit status, or are they paying taxes?
They are not nonprofit. I don't believe these venture capitalist systems are nonprofit. I believe so. Yeah, I don't know all the models, but my understanding is they are pulling it together. But they're bullying. Like we have a member in Colorado, and they are trying to get every dermatologist to join with them so they can band together. They actually took his name and his name of his company and put it in an ad and put their phone number on it. So when people were calling to see him, they were getting diverted to they're doing horrible things, and we're trying to get Department of Justice to come down for conduct, and they're bad news. Mm-hmm. Because because of the mass. Their bargaining power gets really big when they own up if they can monopolize, own every dermatologist in a community, in a region, they get to call the shots. Yes?
This is a question maybe for you or for Beth or later, so I'm not sure. This is, thank you for coming, by the way.
Thank you.
Seriously.
Thank you.
You get the other side, that's all.
You don't have the economics of it.
Right, and that kind of goes to my question it's kind of ironic, our universal health system just in January 2017 got bought by a Catholic nonprofit, one of the largest in the country. And we got the intro last semester speech about how it's great, we're getting a new building, we're getting a 200-bed tower, is the upside.
To answer your question, where does the money go?
And obviously, they sold it as a positive, right? Mm-hmm. And everybody believes in it there. So my question is, I wonder, do you ever get a chance to speak at some of the chapters, or how would we navigate getting somebody like you to speak? I'm sure they wouldn't be very open to having somebody on campus
First, I have to be invited. But I speak a lot, and I'm invited by a lot of places that want to know what's going on. And you can run it up the flagpole and see if there's anybody interested in the other side. But I don't think a lot of hospital administrators really want to hear what I have to say. They really would like me to shut up. So. Yes?
So what if the graph of like the increase in trend of the corporate consolidation?
Which one? The one about the 33 to 50? Oh, yeah, that slide of hospital administrators.
It looked like it started.
Well, it was the 70s. This particular one went over from 1970 to 2009, and since 2011, we've had 31% more of middle-level managers to manage all the Obamacare stuff, the regulations.
So my question is like, what do you know, like kind of what caused it to begin in the first place?
I'll get into some of that. Yeah, we'll talk about the history of government and medicine, monopolies and stuff on that. But yeah,
I haven't looked at my watch. Am I
Yep, and I think we've got time for one more question.
in the back?
So you talked about how Medicare prices a lot of these procedures differently than the hospitals do. How does Medicare cover these procedures? Do they pay for the facility fees as well, or do they only pay a certain amount?
Medicare, good question. Medicare looks at each institution, and it's not one size fits all. They don't just say every single doctor who does a knee replacement should get X dollars, period. They don't do that. They look at the geographics. Some places can do it for less just because of where they are, cost of doing business. And they also do pay facility fees because the hospitals are so good at arguing for them. So Medicare too pays independent doctors less than hospital employed physicians. But what Medicare does a very good job of, from all accounts, they can go in and say, this is what this should cost at your facility in this region with your circumstances. And that's what they will reimburse. It's called Medicare allowable. And what doctors in independent practice look at is, what do I get? They use that as a benchmark, and some of them are getting 50% of Medicare allowable. Some are getting 125% based on their contracts with insurers, and they look at that as the benchmark. Where is their reimbursement falling? And when they start getting 50% of Medicare, they opt out. So that's kind of a really good kind of gold standard, because they've done a good job, amazingly, it's a government agency, but of saying what care should cost. And if the hospital can't hit that mark, it's their problem. It's not the cost.